Moving on to the next clinical vignette, you are evaluating a 3-year-old child presenting with a bowing of legs and X-ray suggestive of rickets. After completing vitamin D therapy in appropriate dosage during follow-up, no appropriate response is noted. What should be the next step in management? First of all, this is a rickets condition. Why? Because you have bowing of legs and X-ray suggestive of rickets, and of course every child with the rickets you have to start vitamin D response. Okay. Now the question is saying that after vitamin D therapy completion also no appropriate response is noted. First of all, what is the response which you look for after completing vitamin D therapy? It is in the X-ray where you will look for a healing white line of rickets, healing white line, which will tell you that the child has responded to vitamin D treatment. What is a white line representing? It is simply the calcium deposition at the end of the bones due to vitamin D action. Okay, very simple. Now in this particular question, it is clearly written that the child is not showing a response. At this time, what should be the next step in the management? Remember, the most common reason why you don't get a response to vitamin D therapy is that non-compliance to treatment. That is an important thing. See, this is not going to be a single 1 day or a 2 day treatment. It is going to go on over a period of few weeks. And most likely the reason why you're not getting a response is the child is not having a proper compliance to treatment or not taking the proper doses. That is what you have to remember. So in this particular child, before even I come to any further conclusion, what I will do, I will check for the compliance. Okay. I will check for the compliance. Okay. And ensure that this child is actually taking the correct duration of treatment as well as in the correct dosage. That is the first thing to be done in this clinical setting. Now let's go on to the next part of the question. The child had a proper compliance to treatment. That means you are asking the question, parents and the child are saying that they are taking the dose in the correct duration as well as in the correct dosage also. Okay, but still there was no response. Okay, now you have to think about some other condition. What could be the other group of condition where you don't actually get a response to vitamin D treatment? This is what we call refractory rickets. This is what we call refractory rickets. Okay, there are so many conditions under refractory rickets. To give you the clue only, the next line of the question will help. What is that? Upon questioning, other children in the family also had similar finding. Maybe the first degree relatives or the siblings are having a similar history, which will tell you that this is a inherited condition. Okay. And in the inherited conditions with refractory rickets, there are two categories actually. There are two categories. One category is called familial hypophosphatemic ricket. PO4 is phosphatemic rickets. Another one is called VDDR, which is nothing but vitamin D dependent rickets, which is characterized by certain defects in the metabolic pathway of vitamin D. Okay, right? These are the two inherited conditions which can be associated with inherited ricket. Now the question is, what should be the most likely possibility in this child? Okay, see, this is a very blanket question where I am not giving you any further information and I am asking out of these two conditions, which is the most likely possibility. This is something like a fact-based question. Out of these two, familial hypophosphatemic ricket is the most likely possibility because out of these two, it is the most common. That is why. Okay, right? It is more commonly noted. So, familial hypophosphatemic rickets should be the number one diagnosis in this particular child. Few further points. Familial hypophosphatemic rickets, the mode of inheritance is X-linked dominant mode of inheritance, whereas vitamin D dependent rickets is autosomal recessive mode of inheritance. Okay, how can we make a distinction between these two conditions? It is based on biochemical investigations only. In familial hypophosphatemic rickets, you'll have normal parathyroid hormone levels, whereas in vitamin D dependent rickets, you'll have increased parathyroid hormone levels. That's how we make a distinction between these two conditions. Okay, that will be the question number 23. Moving on to the vignette number 24. A 2-year-old child is admitted for the hospital care in view of SAM. As a part of management, correction of micronutrient deficiency should be done from the beginning. Of course, it is correct. Sometime back also I was telling you that all children with SAM, you need to do correction or treatment of complication. One of the complication is micronutrient deficiencies. Okay. Now the question is, which micronutrient should not be supplemented at this time? That is what it is. Okay. See, you are beginning the treatment in a child with SAM. At the beginning of treatment, which micronutrient deficiency should not be given. Okay. What is that? Iron is the micronutrient which should not be supplemented at this time. What could be the reason iron should not be supplemented? See, if you see, there are actually two stages of treatment in SAM. First stage is the first week, and second stage is from the second week onwards. Okay, second week onwards. Okay. Now, in the first week of treatment, which is actually called as the stabilization phase, there is no iron which is given. So, iron should not be given in the first week of treatment, and second week onwards, iron should be given in the management. Why do you think so? Iron should not be given in the first week of treatment in a child with SAM. Is it that iron deficiency is uncommon in a child with SAM? Absolutely no. Iron deficiency is actually the most common micronutrient deficiency, not only in SAM, in any child, the most common micronutrient deficiency is iron only. Then why I am saying iron should not be given in the first week of treatment? It is simply because if you give iron in the first week of treatment, there are two problems which can occur. One is there will be increased free radical generation. Number one. Number two, iron also promotes bacterial proliferation in the intestine. And it can cause further worsening in the child's problem. So that is why iron should not be given in the first week of treatment. After the first week, when the child starts improving in appetite as well as the weight gain, you can start giving iron. Okay, that is what is a rationale for not giving iron in the first week of treatment. That is a clinical vignette number 24. Moving on to the vignette number 25. A 6-year-old child is presenting with recurrent diarrhea, dermatitis and rashes involving the neck area. What could be the likely nutrient deficiency? See, this is something which you have to make a diagnosis with the very short information I have given, which is diarrhea and dermatitis. Okay, right? Many conditions can be associated with dermatitis as a part of nutrient deficiencies. Typically, the B complex deficiencies can cause dermatitis. And if you combine the dermatitis with diarrhea, there are two more possibilities. What are they? One is the niacin deficiency or the B3 deficiency, and one more is the zinc deficiency. Both these conditions can be associated with diarrhea and dermatitis as a part of micronutrient deficiency I am talking about. Okay. However, the distinguishing point is what is given in the next line of the question. What is that? Rashes are involving the neck area, which is nothing but the sun exposed area. And this favors the diagnosis of niacin deficiency. Because in case of zinc deficiency, okay, the rash or the skin lesion will be peri-orificial, surrounding the openings like mouth opening, anal opening, like that. Okay, that is where skin lesions are noted in zinc deficiency, whereas niacin deficiency is typically in the sun exposed area. And any name for this rash in the sun exposed area, that is the neck area we are talking about, this is what we call castle necklace appearance. This is what we call castle necklace, something like a necklace appearance in the neck region. Okay, it usually presents as a hyperpigmented, increased pigmented, symmetrical rashes in the neck region called as the castle's necklace. Okay, right. So the likely deficiency is niacin deficiency in this particular situation. And what is the name of this condition? It is what we call it as pellagra. Okay, right. That is what we call it as also as the 3 Ds in pellagra, which is the diarrhea, dermatitis. One more is little late manifestation in the form of dementia. And if this condition is not treated, it can lead on to 4th D. And what is that? Death also can occur. Okay, so that is the clinical situation we are dealing with here. Now, what could be the dietary advice? Of course, I have to advise a diet which should contain a lot of niacin. And niacin is typically present in the egg, cereals, as well as the milk. One more important point is that you have to increase the tryptophan consumption also in this particular child, because you know that tryptophan is converted into niacin. Okay, 60 milligrams of tryptophan will yield 1 milligram of niacin. So that is also something which you have to remember. And next thing is to limit the intake of maize. Okay, right? See, this niacin deficiency is predominantly noted in maize eating population, because in the maize, the niacin is in the bound form. Niacin is in the bound form, and the absorption of the niacin from this maize is very, very less. That is why you have to limit the consumption of maize, especially because there are some population where maize is a staple diet. So that is why this dietary advice has to be specifically given. Okay, so that's about the clinical vignette number 25. Moving on to the vignette number 26. You are evaluating an adolescent male who is presenting with a short stature and having a mild intellectual disability. General examination reveals webbing of the neck, low posterior hairline, widely spaced nipples, and an increased carrying angle. Now, whenever you look at this particular child, based on the given clinical findings, what should be your possibility in this child? You see, short stature is there, intellectual disability, okay, right? And look at the findings which are given in the examination of this child. What is that? Webbing of the neck, low posterior hairline, widely spaced nipples, and increased carrying angle. This would suggest the possibility of Turner syndrome. I think all of you should be knowing about this. Turner syndrome possibility is there. Okay. Now, can this actually be Turner syndrome in this particular condition? No, because Turner syndrome is something which affects only the females. It is something noted only in the females. In this question, it is very clearly mentioning it's a male child who is having all the features. So, is it Turner syndrome? No, it is not going to be Turner syndrome. Something looking like a Turner syndrome, but a different condition. What could be the answer for this? Yes, it is going to be a case of Noonan syndrome. It's going to be a case of Noonan syndrome. That is why Noonan syndrome is also called as the pseudo-Turner syndrome. Pseudo-Turner syndrome. Okay, right? Please remember, Noonan syndrome is an autosomal dominant disorder. So that is why both males and females can be affected by this particular condition, whereas Turner syndrome, only females are going to be affected. Next thing, in Noonan syndrome, you can see there is an intellectual disability, whereas Turner syndrome, always remember that there is usually a normal IQ. Okay, so these are few points of differentiation between the Turner syndrome and the Noonan syndrome. Okay, right? Now, clinically, we have made the diagnosis that it is a Noonan syndrome. Now look at the second part of the question. What is the karyotypic analysis in this particular child? Is it normal or abnormal? Remember, karyotypic analysis will be abnormal whenever you have a condition like aneuploidy, which is encountered in Turner syndrome. But Noonan syndrome is not an aneuploidy. It is basically a gene problem in one of the chromosomes. So the karyotypic analysis is going to be absolutely normal in this particular child. Okay, so what is a genetic defect in this particular condition? It is mapped to chromosome number 12, and the gene which is responsible for this is PTPN11 gene. Okay, that is the basic genetic defect in this particular condition of Noonan syndrome. Okay, right. So that's about this particular clinical vignette. Moving on to the next one, number 27. You have a 13-year-old adolescent male bought by the parents in view of abnormal behavior noted for the past few months. He also has unsteadiness while walking and has few episodes of seizures. Okay, so many neurological problems are noted, like abnormal behavior, unsteadiness while walking, probably an ataxia finding, as well as seizure. So he's definitely having a lot of neurological problems. Okay, on examination, you also notice scleral icterus, that is jaundice is noted. Okay, along with that, he is also having tremors. Also, the boy has brown rings at the edges of the cornea bilaterally. I think this should strike the diagnosis in your particular question. What is that? Brown rings at the edges of the cornea. What is that? It is nothing but the KF ring, or what is called as a Kaiser-Fleischer ring. So you have a adolescent male who is having icterus, probably related to the liver. Okay, probably related to some hepatic dysfunction. Okay, second, KF ring, and third, you have neurological manifestation. put together all these points to the diagnosis of a very, very important condition. What is that? I think most of you should be knowing this. It is nothing but the Wilson disease. It is a Wilson disease. One of the important genetic disorders affecting the liver and the brain. You all know that Wilson disease is due to an autosomal recessive problem associated with chromosome number 13, and the gene defective is ATP7B gene defect, correct? ATP7B gene defect. Okay. Now remember, Wilson's the manifestations are due to increased free copper, or what we call the toxic copper deposition in different organs like the liver and the brain. That is why all these manifestations are going to be present. And please remember, the characteristic finding which you get as tremor in a child with a Wilson disease. What is the name of that finding? This is what we call it as the wing beating tremors. This is what we call wing beating tremors. So all these are very, very characteristic of Wilson disease, which you should be knowing about. Okay. Now the next part of the question is asking about what is the initial screening test we can do. We have to look for the serum ceruloplasmin level, which is obviously going to be decreased in this particular condition. That is one of the screening tests which you can do in this patients. Number 2 would be the urinary copper estimation. The urinary copper levels would be increased in these patients. Okay, these are the 2 screening tests which you can do for this patients. And what do you think is the diagnostic test? Diagnostic investigation is always going to be liver biopsy. Of course, in the liver biopsy, I am going to look for increased levels of copper, typically defined by copper levels of more than 250 micrograms per gram of the dry weight of the liver. This will tell you the diagnosis in a child with a Wilson disease. Okay, so that's about the vignette number 27. Moving on to vignette number 28. You are evaluating a 4-year-old girl with severe learning disability. You notice that her height and weight are normal, but the head appears to be markedly small. Okay. Other notable findings include hypotonia, small eyes, and smooth philtrum with a thin upper lip. So, based on these findings, what is your likely diagnosis? Okay, these are all certain characteristic set of findings which you should be knowing about, which have been asked previously in your competitive exams as well, and should be known very, very clearly. Okay, let us put together the findings and we'll give a diagnosis for this. What is it? One is learning disability, already given in the question. Second, head appears to be markedly small. They are giving you the clue that it is microcephaly. And in addition to microcephaly, you are having hypotonia with the small eyes, smooth philtrum. Okay, what is the meaning of smooth philtrum? Philtrum is the area between the nose and the mouth where you will have grooves in the philtrum. Here there is no grooves. Okay, absence of grooves is what we call it as a smooth philtrum here. Along with that, there is a thin upper lip. So this is a third set of findings. Okay, along with microcephaly and learning disability. Any idea which is this condition? I will give you a clue that this is one of the teratogen exposure in the mother during pregnancy could have resulted in this condition. What is that? Yes, it is alcohol exposure, and the name of this condition is called fetal alcohol syndrome. Fetal alcohol syndrome. Okay, or in short form remembered as FAS. Look at the typical description of a child with fetal alcohol syndrome. Can you see? One is a small head, of course, microcephaly. Next one, you can see the eyes are very small. Then you can see the area between the nose and the mouth. What is that? Philtrum is not having any grooves at all. That is what we call smooth philtrum. Also, compared to the lower lip, the upper lip is very, very thin upper lip. These are characteristic findings of fetal alcohol syndrome. Now look at the next part of the question. What is the most commonly associated congenital heart defect in this condition? It is VSD, or the ventricular septal defect is the most commonly associated congenital heart defect in this condition. So that's about question number 28. Moving on to the clinical vignette number 29. You are evaluating a 3-year-old female child who is having a developmental delay and microcephaly. Evaluation reveals severe MR. Okay, of course, the new term for MR is ID. What is that? Intellectual disability. So severe intellectual disability, hyperactivity, as well as a happy demeanor with the frequent inappropriate laughter and smiling. Child also has jerky movements of the hands. What could be the likely genetic disorder? Here I am giving you that it is a genetic disorder which we are discussing, and based on the findings you are going to tell me the name of the genetic disorders. Okay. See, developmental delay, low IQ, microcephaly can be noted in many conditions. Any condition which is having microcephaly can have low IQ and developmental delay. With this we cannot make a diagnosis. Now look at the other things. What is that? Hyperactivity. One more is a happy demeanor. Happy demeanor along with inappropriate laughter and smiling. This is something which is abnormal. Inappropriate laughter with having always a happy demeanor, okay, or a happy looking face always. Along with that, this child is also having jerky movements of the hands, probably signaling that there may be ataxia as a finding in this particular child. Okay, and because of these two findings, that is a happy demeanor with inappropriate laughter along with ataxic movements of the hands and the limbs, we call this condition as happy puppets. Okay, happy puppets. In fact, this condition is also called as a happy puppet syndrome. Now, any condition strikes your mind? Yes, it is angel man syndrome. Correct. It is an angel man syndrome. Okay, it is an angel man syndrome. I think all of you know it is one of the important conditions which is under the category of which genetic disorder? Yes, it is genomic imprinting disorders. Correct. Okay. So if I ask you what is a genetic defect in this condition, of course, you have to tell it's a genomic imprinting disorder involving which chromosome? It is chromosome 15q. That is long arm of the chromosome number 15. And what is a genomic imprinting defect? It is of course deletion of one of the alleles, whether it's a maternal allele or a paternal allele. It is usually due to deletion of the maternal allele. Okay, right? That is a genomic imprinting defect in this particular Angelman syndrome. Please don't forget there is another genomic imprinting defect also, which is involving the same chromosome 15q, but it is a deletion of paternal allele. What is that? That is Prader-Willi syndrome. Okay, right. So that's about the clinical vignette number 29. Moving on to vignette number 30. You are evaluating a 17-year-old adolescent male with the complaints of muscle pain, stiffness and fatigue when he exercised, especially when he engaged in high intensity activities such as running or lifting weights. Lab finding shows elevated levels of serum creatinine kinase. All this tells you there is some problem in the muscle. If I want to translate it, it is something like exercise intolerance. Correct? Because this male is having a pain and weakness involving the muscles, not during resting state or not during a simple activity. It was only during exercise, and that too you can see only during a high intensity activity. That is what. And probably due to muscle damage only, the serum CK levels, creatinine kinase levels are also elevated. All this tells you there is a muscle problem in this particular child. In view of similar findings in other family members, of course, a genetic disorder is also suspected. So which genetic disorder has got a propensity to involve the muscles and characterized by exercise intolerance as an important finding? Yes, it is muscle glycogen storage disorder, muscle GSD, muscle glycogen storage disorder. Because you all know that in the muscle, glycogen is needed for ATP generation or energy production during the times of exertion or exercise. That is not going to happen in case of muscle glycogen storage disorder, because here the glycogen is not utilized for ATP generation during exertion. So that is why muscle glycogen storage disorder typically they present with exercise intolerance. Now the question is, what is the most common muscle glycogen storage disorder? The most common in this would be, yes, what is the answer? It is McArdle's disease. McArdle's disease, which is actually type 5 glycogen storage disorder due to deficiency of which enzyme? Yes, it is myophosphorylase deficiency. Myophosphorylase deficiency. That's what you have to remember as the genetic problem in this particular condition. Okay, right. Now, this patient, let's imagine, is also reporting burgundy colored urine. Okay, something like a brownish red colored urine after an exercise. What is the likely diagnosis? See, I told you these patients have exercise intolerance, correct? That exercise intolerance can also result in rhabdomyolysis. Rhabdomyolysis, which can be associated with what? Release of myoglobin from the muscle, which is being released in the urine, myoglobinuria. And this myoglobinuria is what is presenting as burgundy colored urine after an exercise or an exertion. Okay, that's what you have to remember. In an exceptional case, if the myoglobinuria is so marked, it can even precipitate acute kidney injury also in a patient with myocardial disease. So you have to watch out for this possibility, and you will always advise these patients not to take up high intensity activities, okay, because that can precipitate weakness as well as it can potentially cause rhabdomyolysis and myoglobinuria as well. Okay, so that's about the clinical vignette number 30. Moving on to clinical vignette number 31, you have a 15-year-old short female who presents because the menses have not yet started. Her breast development is Tanner stage 1 and there is a scant pubic hair. Physical examination is also significant for decreased femoral pulses. Okay. The question is, what is the best next step in evaluating her condition? Now, if you see this question, there are a few important findings which are given. It's a short female to begin with, and she has not yet attained menses and having a scant pubic hair. And you see Tanner stage 1. What is the meaning of Tanner stage 1? I have already told you that it's a pre-pubertal situation, meaning child has not yet attained puberty. Is this normal for a 15-year-old child to not attain puberty? Not at all. Definitely this is delayed puberty. Definitely this is delayed puberty in a child. Please recollect, what is the definition of delayed puberty for a female? After 13 years, if the secondary sexual characteristics are not attained, then it is called delayed puberty. So we have a short female who is having delayed puberty. What should be the best next step in evaluating her condition? See, there are many causes for delayed puberty, but female, short stature, along with delayed puberty should make you think about the possibility of Turner syndrome. Should make you think about the possibility of Turner syndrome. So now, what should be the best next step in the evaluation? Yes, answer is going to be karyotyping. This karyotyping is going to bring out the diagnosis in the form of absent X chromosome, which is 45XO as the characteristic karyotype in Turner syndrome. Now you try to correlate this history, which is significant, a physical examination is significant for decreased femoral pulses. What could be your understanding? Yes, it is something signaling to a possibility of congenital heart disease. What could that be? Yes, it is coarctation of aorta. It is coarctation of aorta. This coarctation or narrowing is going to affect the descending aorta. That is why the lower limb pulse, like the femoral pulses, are going to be decreased. And you all know that in Turner syndrome, coarctation of aorta is one of the most common congenital heart diseases. Okay, right. Now, the next part of the question is, in this particular condition, what is the neonatal manifestation? See, we all know about so many manifestations like webbing of the neck, short posterior hairline, okay, right, flat chest or the shield chest, along with the widely spaced nipples and cubitus valgus. All these are going to be evident as the child grows up. But in the neonatal period, none of these manifestations may be prominent. So what would be the finding which will make you think about the possibility of Turner syndrome in a neonate? It is nothing but edema of the limbs, edema of the upper limbs and the lower limbs. And what is the reason for the edema? It is nothing but lymphedema, okay, causing swollen limbs as a clinical feature of this Turner syndrome. Okay, right. That's about the vignette number 31. Moving on to vignette number 32. We have a 10-year-old boy who is presenting with myoclonic seizures and a recent change in the personality. His past history is significant for an episode of fever with rash at 1 year of age, which resolved spontaneously. EEG is abnormal. See, this is a 10-year-old boy and a history at the age of 1 year is given, meaning they want you to correlate that particular history with this presentation. See, myoclonic seizures along with change in the personality tells you some neurological deterioration in this boy happening at the age of 10 years. And if you want to correlate with this history at the age of 1 year, what is the history? Fever with rash. Okay, what are the common conditions which present with fever with rash? It includes the viral exanthematous fevers like chickenpox, measles, rubella. All these are the common exanthematous fever which can present in a young child. However, if you can recollect, most of these fevers, okay, will not have any chronic neurological problem except only one condition. What is that? Yes, it is measles. It is measles, which has got a chronic complication. It has got a chronic complication in the brain. What is that chronic complication? It's in the form of SSPE. What is that? Subacute sclerosing panencephalitis, which typically presents with this neurological deterioration. Like the child would show seizure activity in the form of myoclonic seizures as well as change in the personality as well as cognition. That is how they present with. Subacute sclerosing panencephalitis is the most likely possibility in this particular condition. Now the question is, what is the most appropriate investigation to arrive at a diagnosis? See, we have to prove that it's a chronic complication of measles. So we have to look for an evidence of measles, chronic evidence of measles in this particular child. So what we can do the CSF analysis. And what are you going to look for? IgG antibodies. IgG anti-measles antibody is what I am going to look for in the CSF, and that would establish my diagnosis as SSP in this particular condition. Now one more question. EG is abnormal. Obviously in a child with recurrent seizures, EG is going to be abnormal. Any characteristic EEG finding you can correlate for SSP? Yes, it is characterized by burst suppression pattern on an EEG. Along with that, you get periodic slow wave complexes. Periodic slow wave complexes. This is the characteristic EEG finding in a child with subacute sclerosing panencephalitis. Okay, right. So that is for the clinical vignette number 32. We move to the next vignette. A 9-year-old girl is presenting with weakness of the lower body for 3 days of duration. And she had a history of diarrhea 10 days back. So this, I want you to correlate that following an episode of diarrhea, child is developing weakness of the lower limbs. Okay, 10 days after a diarrheal episode, child is developing weakness of the lower limbs. Okay, lower limb weakness. Okay, right. Now you see she is otherwise well. Physical examination reveals symmetrical weakness. That's also an important clue. Symmetrical weakness that is involving the ankle and knees with a normal strength of the hip muscle. So the lower parts of the body are affected, like the knee and the ankle are affected. Bilateral deep tenon reflexes were absent with a normal sensation. Okay, right. Now this is an important clue. Bilateral deep tenon reflexes absent tells you what type of weakness is it. Is it a UMN weakness or a LMN weakness? Definitely this is a LMN weakness, lower motor neuron weakness. So this is what is a summary of the case. It's a post-diarrheal condition wherein child has developed weakness, and that too symmetrical LMN type weakness in the lower limbs. What could be the likely diagnosis? This is a typical presentation of a condition which is post-diarrheal. What is that? It is GBS or the Guillain-Barré syndrome. It's a Guillain-Barré syndrome wherein it's a post-infectious demyelinating disorder, polyneuropathy, demyelinating polyneuropathy. Okay, post-infectious demyelinating polyneuropathy. This is a characteristic presentation of this particular condition. Now, how this condition usually present? It starts as weakness in the lower limb and starts going upwards, or this is what we call the ascending weakness. This is what is called ascending weakness. And the name of this description, okay, ascending symmetrical weakness is what we call Landry's paralysis. Landry's paralysis. Okay. This condition usually occurs following a diarrheal episode. Rarely it can occur following a respiratory infection also. And in the diarrhea, the commonest organism which is implicated is Campylobacter jejuni. Okay, Campylobacter jejuni is the commonest organism implicated in this particular condition. So this is a very typical case of Guillain-Barré syndrome. The points were post-diarrheal condition. Number 2, it's a symmetrical lower motor neuron type of weakness starting from the lower limbs. Okay, right. Now, next day after admission, think you have admitted this child, and next day after admission, the weakness progressed to involve the hip muscles also. I have already told you it is an ascending paralysis. So initially it was in the lower parts like the ankle and the knee, then it has ascended up to the hip muscles. And if it is going to ascend further, it is going to ascend into the trunk area, and potentially it can involve the respiratory muscles also. In fact, 25% of the patients have respiratory muscle weakness, and this can even proceed on to respiratory failure also. That is why when you have an acute or a fast progression of weakness in these children, you have to start some medication to halt the progression of this weakness. So which medication would be very, very helpful, or what is the drug of choice? It is going to be intravenous immunoglobulin, typically given in the dose of 2 grams per kilogram. We don't give it as one full dose itself. Over a period of few days, like 2 to 5 days, we give this particular dose, and the child would respond to this particular treatment. And this is purely to halt the progression of the weakness in Guillain-Barré syndrome. Please keep a note of that. Okay, right. So that's about this particular condition of Guillain-Barré syndrome or the clinical vignette number 33. Moving on to the next clinical vignette. We have a 7-year-old child who is presenting with malaise, fever and headache of 3 days duration, followed by left-sided focal seizures on the day of admission. Okay. Now see, whenever you have a child with fever and seizures, of course, headache, malaise, all those things, you have to think about the possibility of meningitis or meningoencephalitis. Especially focal seizures would make you think about the possibility of meningoencephalitis, where the brain tissue is also affected, meningoencephalitis. Okay. So obviously in this condition, I am going to do a lumbar puncture to obtain the CSF, and CSF analysis reveals the following findings. What are they? Pleocytosis means increase in the cells, cell count. Of course, in meningoencephalite, you are expecting that. Mildly elevated protein and normal sugar. This is an important clue. So what type of organism you are dealing with? Is it a bacteria or a virus? This very clearly tells you that it is a virus. It is a virus-associated encephalitis. It's a virus-associated encephalitis. Okay, meningoencephalitis. So now the question is, what is a likely diagnosis? What is a likely diagnosis? See, many viruses can cause meningoencephalitis, but presence of focal seizures and typically in the setting of meningoencephalitis points to the diagnosis of herpes encephalitis. Herpes encephalitis, and that to what herpes we are dealing with? It is HSV1, herpes simplex virus 1 encephalitis. Okay. I would want you to make a note of this. Usually in viral meningoencephalitis, we study the protein count is normal. However, please remember in herpes encephalitis, there can be mildly elevated protein. Please make a note of this. Don't think it is bacterial meningitis just because it's an elevated protein. No, mildly elevated protein can be noted in viral meningoencephalitis like HSV encephalitis also. This should be noted. Okay, right. So now the next part of the question, what is the investigation of choice in this particular condition? So which investigation will you do? See, HSV virus has got a propensity to affect the temporal lobe of the brain. So in order to see the temporal lobe involvement, what is the investigation which you're going to do? You can do MRI brain. That is okay. But it will only tell you the temporal lobe is affected in a setting of encephalitis. It is not always confirmatory for HSV1. So now the question is different. To confirm HSV1 encephalitis, what is the testing of choice? Very correct. It is going to be PCR testing for HSV1 virus. That would be the investigation of choice. Okay, remember you can do MRI brain. MRI brain will show temporal lobe involvement. However, that is not diagnostic of HSV1 encephalitis. It is characteristic but not diagnostic. If you want to diagnose, it has to be based on PCR testing for HSV1 virus. Okay, right. Now one more question if I would want to ask, what would be the drug which you are going to start in this particular setting? Of course, you have to start something for HSV1 virus, which is intravenous acyclovir. Correct. Intravenous acyclovir will be started in this particular situation. That's about the clinical vignette number 34. We move on to the next one, 35. You are evaluating this 3-year-old child who is presenting with recurrent seizures, and you also notice the following finding on clinical examination. See, this is a neurological condition, that is why seizures are present, and along with that, this child is also having this characteristic red colored patch, which is definitely a big patch as well as an elevated patch surrounding that eyes area in this area. What is this? Yes, this is the very, very classical port wine stain, also called as a nevus flammeus. Which condition is this very characteristic? Yes, it is very characteristic of Sturge-Weber syndrome. Which is one of the neurocutaneous syndromes where you have a finding in the skin as well as in the neurological examination of CNS findings also would be present. Okay, and port wine stain is very, very characteristic of Sturge-Weber syndrome. Port wine stain actually represents what? It actually represents an hemangioma, okay, in the area of distribution of the first ophthalmic division of the trigeminal nerve. Okay, right? That is what is the very characteristic finding. It's an angioma involving the distribution of first division, ophthalmic division of the trigeminal nerve. That is what is Sturge-Weber syndrome. Okay, right. Now the question is, what is a characteristic intracranial imaging finding you are expecting in this particular child? Remember, this is a facial angioma. It can be associated with angiomas in the brain also. What is that called? It's called leptomeningeal angioma. It is called leptomeningeal angiomas. And these leptomeningeal angiomas, they typically display a very characteristic calcification. Okay, you can see in the brain imaging. What is that? Yes, it is a tram track calcification. Intracranial calcification will be noted. Very, very characteristic of leptomeningeal angiomas present in this particular condition. Okay, right. Now, these children, they also have seizures. But what type of seizure they are going to have? This is what is important. They develop recurrent focal seizures. Very, very important. It is developing recurrent focal seizure. This point you should know about it because I am going to ask you the next question. Suppose this child is having, this child is having recurrent seizures. What would be the drug to control seizure in this condition? You can answer only if you know that it is a recurrent focal seizure. And what is the drug of choice for focal seizures control? It is oxcarbamazepine. That is the drug of choice or the antiepileptic of choice to control seizures in this particular condition. Okay, fine. If I want to ask one more question, what is the ophthalmological manifestation of port wine stain? You can have angiomas, okay, in the anterior chamber of the eyes also, which can interfere with the drainage of the aqueous humors and all. So what is the finding which you can get in the eye? Yes, it is glaucoma. That is a finding in the eye characteristic of Sturge-Weber syndrome. These are some of the salient points about this particular neurocutaneous syndrome of Sturge-Weber syndrome. Okay, right. Moving on to the next clinical vignette, number 36. You have an adolescent female who is presenting with prolonged menstrual bleeds for the last 2 years. It is also noted that she has regular menses before that. So probably at the time of in starting of puberty and few years after that, she had regular menses. But for the last 2 years, she's having prolonged irregular menstruation. That is what. She also has a history of frequent nose bleeds as well as excessive bruising. So prolonged menses, nose bleeds, excessive bruising all tells you that we are dealing with the possibility of a bleeding disorder in this particular child. Common bleeding disorders which should come to your mind would include something related to the platelets, like platelet dysfunction or thrombocytopenia like acute ITP and all. Is it going to be a platelet dysfunction associated bleeding in this child? It is no, because platelet bleeds only will have skin bleeds like petechiae, purpura, like that. But in this child, you can see it is not only skin bleeds, it is involving the mucosa also. That is why you have nose bleeds, nasal mucosa, as well as the menstrual bleeds. Okay, so this is not a platelet bleed. This is not a platelet related bleeding disorder. What is the other condition which comes to our mind whenever we say bleeding disorders? It could be a clotting factor defect, clotting factor defects, or it could be a coagulation disorder. Okay, that can also be possible. Now, please remember, coagulation disorders or clotting factor related disorders are characterized by deep bleeds. What are the deep bleeds? It includes the muscle hematomas as well as the joint bleeds and all. It's clearly given in the question. Can you see the next line of the question? There is no history of joint bleeds. There is no history of joint bleed. So this also tells you that it is not going to be a coagulation disorder. Also, if the child is on any medication like anticoagulants and all, you may expect bleeding as a manifestation, and it is clearly written child is also not on any medications. So that type of medication related bleeding is also not possible in this child. So what is this condition which is characterized by recurrent episodes of mucocutaneous bleeds, in this particular adolescent girl? Yes, it is going to be a case of VWD. What is that? Von Willebrand disease. Von Willebrand disease. In fact, von Willebrand disease is the most commonly inherited bleeding disorder. Most commonly inherited bleeding disorder. Very, very important point. Okay, and it typically presents with mucocutaneous bleeds, and in females it usually presents with menorrhagia or excess menstrual bleed. That is a typical presentation of the von Willebrand disease. And what is the most common mode of inheritance? Inherited, all right, but what is the mode of inheritance? It is usually inherited as autosomal dominant condition. Very, very important. Usually inherited as autosomal dominant condition. So here clinically my diagnosis is going to be von Willebrand disease. What would be the investigation for definitive diagnosis? See, you have to tell a specific test. Okay, you should not simply say the coagulation testing and all. Yes, of course, there can be some abnormalities expected, but lab investigation for a definitive or the best test for diagnosis would be something like this: measurement of von Willebrand factor antigen levels. Von Willebrand factor antigen level, that can be done. One more important test is we can look for the activity of von Willebrand factor with the help of something called as a cofactor assay. What is that? Ristocetin cofactor assay, which will test for the activity of von Willebrand factor. So this is for von Willebrand factor activity. This would be the definitive test to diagnose von Willebrand disease. Please keep a note of this. This is how you diagnose this condition. Okay, right. So that's about the clinical vignette number 36, which has been described. Moving on to vignette number 37. You have a 6-month-old baby who is presenting with a history of stridor since birth. This is a stridor since birth itself, it is present. Okay. Mother notices that the baby is feeding well and growing well also, meaning it is a benign condition. See, only because it is benign, it is not affecting the feeding and growth of the child. Okay, if it's a dangerous situation, of course the weight gain would have been inadequate, feeding difficulties could have been present like that. Okay, so what we are concluding at this time, it is something related to the respiratory tract, and because it is stridor, what does stridor generally indicate? What type of problem? Upper or lower respiratory problem? Yes, upper respiratory problem, and that too laryngeal obstruction. It generally indicates a laryngeal obstruction. So something related to the larynx and something which is a benign condition. That is what is the idea which we have. Mother also notices that the sound is more pronounced, that is a stridor sound we are talking about, is more pronounced after feeding when the baby is sleeping. That is what is the characteristic finding also given. So what could be the possibility? See, whenever you have a stridor since birth, you should think about the strong possibility of laryngeal anomalies. Very important point. Laryngeal anomalies. And there could be two important laryngeal anomalies which can be associated with stridor after birth. One is the most common one. What is that? Laryngomalacia. Wherein due to softness or decreased tone of the structures in the larynx, they cause an airway obstruction and cause stridor. And one more would be subglottic stenosis, which is also causing narrowing in the upper part of the respiratory tract and causing the sound of stridor. So you have to consider these two possibilities, correct? You have to consider these two possibilities. Now, what could be the condition in this? Both can be possible. You can say most common is laryngomalacia and then you can finish the diagnosis there. But there is also one more point which I want you to remember. What is that? Yes, this is something which is more pronounced after feeding. Can you see that? As well as when the baby is sleeping. When the baby is sleeping means which position the baby usually sleeps? Supine position. So can I say this stridor is also having a positional variation? Correct? Okay. Now you can tell me, out of these two conditions, which condition has a positional variation of stridor? That is laryngomalacia. Positional variation is characteristic of laryngomalacia, whereas in subglottic stenosis, there is no postural or positional variation. That is something which is very, very important. So for all likely reasons, in this particular child, the diagnosis is going to be laryngomalacia. Okay, right. Now suppose in this question I ask one more. What would be the advice or the treatment advice for this particular child? Or what will you tell the mother? You tell the mother that there is a benign condition, and as the child grows older, this condition will spontaneously settle. Usually by around 12 to 18 months of age, okay, this condition will spontaneously settle. So what is going to be the management of this condition? It is nothing but reassurance. And tell the mother about the benign nature of this particular condition. Okay, right. Now, if I ask one more question, what is the clinical finding which would further confirm the diagnosis? I've already given you the clue. What is that? Positional variation of stridor will tell you clinically that this is laryngomalacia. Okay, just to elaborate it and to make it more clearer, stridor in a child with laryngomalacia will be present when the child is in the supine posture. When the same child is put in the opposite way, what is that? Prone posture, the stridor will disappear. Okay, this is very, very characteristic clinical finding of this particular condition of laryngomalacia. Okay, of course you can do laryngoscopy also. That is not a clinical, it's an investigational finding. If you do the investigation laryngoscopy, what you can see? You can typically see the shape of the epiglottis. What is that? Omega shaped epiglottis. These are the salient points about laryngomalacia and the clinical correlation which I want you to make a note of. Moving on to the next scenario, clinical vignette number 38. You have an 18-month-old boy who's brought to the emergency room with a sudden onset of coughing. Prior to the onset of symptoms, he was playing with his elder cousin in the study room. There is no preceding history of any respiratory illness and the child is afebrile. Okay. There are no similar episodes also in the past. This is just a sudden respiratory problem in the form of sudden coughing episodes in this child. That's all is the history which we are having. There is nothing to suggest an infection because the child is afebrile. It is an acute presentation. There is no previous history. Okay. And also there is no preceding history of any respiratory problems also. Okay. So it is just an acute sudden presentation with repeated coughing. That's all we have. Examination reveals respiratory rate of 44, which is definitely increased for a child 18 months old. Okay, so fast breathing is present. SpO2 is okay, 96% in the room air. Now, auscultation reveals wheezing in the right hemithorax. Wheezing in the right hemithorax. So, sudden coughing and also wheezing in the right side. What is the likely possibility in this child? Is it going to be an infection? Absolutely no, because there is no fever. Is it going to be like asthma, which is characterized by wheeze? No, because it's very clearly written there is no similar episodes in the past. Asthma is a condition characterized by recurrent episodes. So, what do you think is a possibility wherein a small child playing very normally suddenly develops a breathing difficulty with wheezing? This is going to be a foreign body obstruction. I am writing FB, which is nothing but foreign body obstruction. Foreign body obstruction. Which area? Is it in the upper or lower respiratory tract? Obviously, wheezing sound will tell you that this is in the lower respiratory tract, most likely in the bronchus area. Okay, of course, right side of bronchus only, because where are you hearing the sound? It's in the right side of the hemithorax only. So, for all practical purpose, in this particular condition, I am dealing with foreign body obstruction in the right bronchus area. That is what should be my clinical diagnosis. What should be the next step in the evaluation? Next step I will look for is an X-ray finding. In the X-ray, I can get two type of finding. One due to partial obstruction, other due to complete obstruction. Complete obstruction. Complete obstruction, you can easily imagine. For example, right bronchus, this is completely occluding the bronchus. What happened? Air will not go beyond that obstruction. So, the lung fields below that area will show a collapse. Okay. Collapse of the lung fields will be noted, corresponding to the segment of the bronchus which is actually occluded. Okay. This is for a complete obstruction. In partial obstruction, what happens is that the air goes in and air cannot come out. This is what we call air trapping effect. And because of an air trapping effect, what you will get? The affected lung fields will have a increased size, or there will be hyperinflation of the lung fields. Hyperinflation of the lung fields. So, X-ray will give you a clue to what type of obstruction we are dealing with, whether it's a partial or a complete obstruction. Okay, fine. Now, what do you think will be the final management? What do you think will be the final management? Anyway, this is foreign body occlusion in the airway. You have to remove out with the help of what? Yes, bronchoscopy. And what type of bronchoscopy? It is rigid bronchoscopy. Rigid bronchoscopic. This is the management of choice in the lower airway foreign body obstruction. Okay, that completes the clinical vignette number 38. Moving on to the clinical vignette number 39, you are evaluating a 2-year-old male child with failure to thrive and admitted with pneumonia. The baby has been admitted twice before with the pneumonia. So you can see that this child is not only having pneumonia at present, there were previous episodes also, which is nothing but recurrent pneumonia is a feature in this particular child. Recurrent pneumonia. Okay, right. Please remember, any child who is having 3 or more episodes of pneumonia in a lifetime is said to be having recurrent pneumonia, and this child has that. Other significant complaint is that child is having chronic diarrhea with a history of delayed passage of meconium since birth. See, chronic diarrhea means a long-standing diarrhea which is of non-infectious origin. And usually in a childhood setting, okay, it is something related to conditions like malabsorption. Okay, so now we have a condition which is going on for a long period of time in this particular child and affecting multiple systems. One, respiratory in the form of recurrent pneumonias. Other, gastrointestinal tract in the form of chronic diarrheas. Okay, what could be the likely diagnosis? So here we are dealing with a condition of multi-system origin, which is going to be a case of any clues in this, any diagnosis we have at this time involving the respiratory and the gastrointestinal tract. Yes, I will try to correlate with the history of delayed passage of meconium little later. Yes, any clues with this two itself? It is a condition of cystic fibrosis. Cystic fibrosis. Okay, right? We all know it's one of the important life-threatening genetic disorders characterized by a multi-system involvement. Okay, right? And in cystic fibrosis, the main important clues were one is recurrent pneumonia. Second, cystic fibrosis is also characterized by malabsorption, which is the possible reason for chronic diarrhea, failure to thrive and all in this particular child. Okay, now can anybody correlate with the history which is given as delayed passage of meconium after birth? There are many conditions which can cause delayed passage of meconium. In cystic fibrosis, what happens? The meconium becomes thick and is getting stuck inside the intestine. That is why it is passed out very late. What is this condition called? Meconium ileus, which is the clinical correlation for delayed passage of meconium after birth. So clinically, my diagnosis is going to be cystic fibrosis for this particular condition. Okay, we all know so many tests can help in the diagnosis, like you can look for the CFTR gene mutations, and also you can look for elevated sweat chloride levels, which can help in the diagnosis of this condition. Okay, right. Now the next question I have is, what is a neonatal screening test for this particular condition? Okay, any answers for this? It is something called as IRT. What is that? Immunoreactive trypsinogen. Immunoreactive trypsinogen levels will be elevated in this particular condition. So increased IRT is one of the neonatal screening tests for this particular condition. So that was about the clinical vignette number 39. We are moving on to vignette number 40. A 4-month-old child is admitted with repeated episodes of vomiting or feeds. This baby has gained 700 grams since birth with a birth weight of 2.7 kg. Just make a clinical correlation here. Is it normal weight gain? See, normally a baby will gain about 30 grams per day in the first 3 months. So that means by the end of 3 months, the baby should have gained, what is that? A baby should have gained in 1 month. How much? 1 month it should be 30 into 30. How much? 900 grams child should have gained in 1 month itself. But this baby is already 4-month old, okay, and gained only 700 grams since birth. So definitely this is a very, very inadequate weight gain. Okay, right? So this baby is having inadequate weight gain as well as repeated episodes of vomiting. And on examination, no mass is palpable. See, why should you examine the abdomen? Remember, repeated vomiting will tell you the possibility of gastrointestinal obstruction. Of course, proximal gastrointestinal obstruction, something like esophageal atresia, pyloric stenosis, duodenal atresia, all those conditions. So that is why we are examining the abdomen to look for a mass. No mass is palpable, is very clearly given, and tenderness or flea fluid in the abdomen is also absent. So in this particular child, pyloric stenosis possibility is very less because that would have presented with a epigastric swelling. Okay, right? So that is out. On passing a nasogastric tube, no resistance is encountered and chest X-ray appears to be normal. This is also helping us to exclude one other condition. What is that? Esophageal atresia. That can also present with repeated vomiting episodes since birth. However, in esophageal atresia, as you pass the nasogastric tube, you will encounter resistance. Number one. Number two, when you take the X-ray, there will be coiling of the nasogastric tube in the upper part of the esophagus itself, which is clearly not given in this question. So that possibility is also out. So the possibility of GA obstruction causing repeated vomiting in this child is actually very, very less in this. So what I am talking about is a non-obstructive condition which is associated with recurrent vomiting episodes in a small child. Can any of you make a guess at this time? What could be the likely possibility in this child? It's a condition called as GERD. What is that? Yes, it is gastroesophageal reflux disease. Remember, in older children or in adults only, it typically presents with the conditions like the heartburn and all. Okay, for a small child and all, the presentation would be repeated episodes of vomiting with inadequate weight gain. Once you have ruled out the surgical condition like esophageal atresia, pyloric stenosis and all, then you have to think about the possibility of GERD, which is a typical presentation in this particular child. So the likely diagnosis is going to be GERD because I have ruled out the surgical condition like anomalies causing GE obstruction in this particular child. Okay, right. So now, how I am going to evaluate this child? First of all, I have to prove that there is a reflux of stomach contents into the esophagus. For that, pH monitoring is important, and an important investigation which we do nowadays is multi-channel intraluminal impedance monitoring with pH measurement, along with the pH measurement. That is what we are doing as an investigation in cases of gastroesophageal reflux disease. So which medication would help in the improvement of the symptom? It is obviously going to be proton pump inhibitors like omeprazole, lansoprazole and all can be helpful in the management of this condition. Okay, right. Remember, even before we start with the this drug treatment, okay, we have to provide something called non-pharmacological therapy, which is basically elevating the head end of the baby during sleeping. Okay, it is not too much elevation, like around 20 to 30 degree elevation is required, so that it would decrease the occurrence of reflux in this particular baby. And if it is not responding to that, then definitely we have to start medication, and the drug of choice is proton pump inhibitors. Okay, that will be about the clinical vignette number 40. Moving on to the next vignette 41. You have a 5-day-old male baby who is brought by the mother to the OPD with the complaints of not passing meconium since birth. Remember, normally a baby should pass meconium within how many hours of birth? Okay, usually they pass soon after birth, but within 48 hours of birth, baby should pass meconium. Now this baby is already 5 days and not passing meconium, definitely signals some abnormality. Okay, feeding was normal and there is no history of vomiting or feeds. Okay, see, on evaluation, abdominal distension was noted with normal bowel sounds. Okay, see, in this situation, what you will think about? Baby is not passing meconium since birth, so it is something related to the lower part of the intestine through which meconium comes out. So first thing I will do is, I will do the examination of the anal region. I will look for the opening of the anus, whether there is any imperforate anus and all. So that is what was done in this case also. Can you see? Visual inspection of the anus reveals no obvious abnormality, meaning the anal opening is normal and there is no imperforate anus. So now I have to evaluate something above the anus, like the rectum area and all. So this question is now going to be like this. What should be the next step in the evaluation? Okay, what will you see? Very, very simple. I will put a glove, and with a gloved finger, I will do the per-rectal examination, PR examination, per-rectal examination, where I will try to look for some abnormalities in the rectum region, if at all it is present. Okay, right? So this should be the logical sequence of evaluating a child who has not passed meconium. First, you have to examine the anal region, and if there is nothing found on anal inspection, then you have to do the per-rectal examination. Okay, right. Now look at the next part of the question. Suppose, considering the previous case scenario, I am saying you a straight statement that rectal biopsy is revealing the diagnosis. What could be the likely possibility? Here, I am giving you a direct clue as a definitive investigation which is telling you the diagnosis itself, and based on that I am asking what could be the condition. Any condition where rectal biopsy will tell you the possibility in a child who has not passed meconium? Yes, anything strikes your mind now? Yes, it is a case of Hirschsprung disease. It is a case of Hirschsprung disease, which is a condition of absence of ganglions, aganglionosis. Ganglions are absent, and that is what we can pick up with the rectal biopsy. And remember, Hirschsprung disease is one of the important conditions where the rectum, the usual area affected in Hirschsprung disease, becomes narrow, and because of the narrow rectum, the meconium is not able to pass through it. This is the condition where rectal biopsy will clinch the diagnosis and the answer for this particular question also. Okay, right. That will be the clinical scenario number 41. Moving on to the clinical vignette 42. You are evaluating a 7-year-old female child with the complaints of tiring easily during physical activities and often complaints of shortness of breath. Okay. Physical examination reveals parasternal heave, widely split second heart sound with a grade 4/6 ejection systolic murmur heard in the second and third left intercostal space. See, when a lot of findings like these are present, like murmur, some problem in the heart sound, even the shortness of breath and exertion during physical activities or exertional dyspnea, all these tells you to the possibility of heart disease in the child. And for a young child, you should always consider the possibility of congenital heart disease. Okay. Question is, what is a likely clinical diagnosis? You see, we make a diagnosis with characteristic set of findings, either in the auscultation or something in the clinical examination of the cardiovascular system. Is there anything specifically given in the question to make you think about one particular congenital heart disease? See, we can divide congenital heart disease into two varieties, cyanotic and acyanotic congenital heart disease. Here, there is no mention of cyanosis in the question. So that makes me think about the possibility of acyanotic congenital heart disease. Is there any clue? The common acyanotic congenital heart disease are like left to right shunt, like ASD, VSD, PDA, as well as obstructive lesions like coarctation of aorta. Is there any clue in the question? There is an important clue in the question which says very clearly that this child is having wide splitting of the second heart sound. This is very characteristic of one congenital heart disease. What is that? Yes, it is atrial septal defect. Okay, that itself will clinically tell me that it is possibility of atrial septal defect. Are you able to follow this? Okay, right. Now this grade 4/6 ejection systolic murmur and all, they are all not due to ASD itself. Instead, it is a flow murmur which is noted in atrial septal defect. Okay, right. So that cannot be a diagnostic murmur in this setting, but the diagnostic clinical finding I have already told you is wide fixed splitting of second heart sound. Okay. Now look at the next part of the question. Same scenario only. Suppose in this particular child, echocardiography reveals the diagnosis as ostium primum ASD. Okay. Remember, it is not the common type of ASD. The common type of ASD is ostium secundum ASD only. But I am saying that echocardiography tells me the final diagnosis, which is ostium primum ASD. Now the question is, in ostium primum ASD, what is the ECG finding? See, generally in a case of atrial septal defect, you will understand that there will be overloading on the right side of the heart and you are expecting a right axis deviation. But in case of ostium primum ASD, there will be LAD or left axis deviation. Why so? See, suppose I draw the atrial septum like this. Okay, right? Left atrium and right atrium. This part is actually the ostium primum area. And please remember, ostium primum area is in close proximity to the atrioventricular valve. Can you see that? And most number of cases of ostium primum ASD, there will be associated valve defects also. And this especially involves the left-sided valve. What is that valve we are talking? Mitral valve. It typically results in mitral insufficiency. And this mitral insufficiency leads to the problem of left ventricular overload. This is one of the reasons why you get left axis deviation. Not only that, there can also be associated anomalous atrioventricular conduction system on the left side of the heart. Atrioventricular conduction system anomalies are present on the left side of the heart. That is also predisposing to the development of left axis deviation. So this is one of the unique findings. I am putting a star there to tell you that it is one of the unique finding in ECG which was associated with ostium primum type of ASD. This is one of the questions which you should definitely make a note of. Okay, right. Then we move on to the clinical vignette number 43. This is a picture of a neonate. And I am putting up the scenario like this. You are evaluating a neonate who was noted to have an abnormal heart rhythm on ECG. Following is a clinical picture of the baby. See, abnormal heart rhythm tells you something like a conduction problem, something like arrhythmia, something like that. It's a rhythm abnormality. Okay, right? And this is a clinical picture of the baby also. Okay. Now the question is, which medical condition in the mother could have resulted in this occurrence? So I want you to correlate some problem in the mother and with the set of findings. What are the findings? One is abnormal heart rhythm. That is already given in the question. Second is, you are seeing some annular lesion. Can you see that? Some round reddish lesion, something like a ring-like lesion or a discoid lesion like that. It is something like a rash, something like a rash which is discoid or ring-like and noted in the face of the baby. Which condition? And try to correlate this with the medical condition in the mother. Yes, it is a case of, yes, neonatal lupus, wherein systemic lupus erythematosus in the mother could have resulted in the occurrence of this particular condition. Okay. Now, any idea what could have gone wrong? SLE is a condition of autoimmune disorder. So many autoantibodies are there, and some of the antibodies, they actually cross the placenta and cause these manifestations in the baby. One in the form of a rash, and second in the heart. And what is that conducting? And what is that heart rhythm abnormality? Yes, it is something like fetal heart blocks. Fetal heart blocks. So what is the problem? These antibodies, they affect the conducting system of the heart, like SA node, AV node, bundle of His like that, and they are going to cause heart blocks, which will be manifesting as abnormal rhythm on a ECG. Are you able to follow this? Okay, right. Now the question is, what is the likely antibodies which are implicated in this condition? See, not all antibodies will cross the placenta and will cause problems in the baby. It is a specific set of antibodies. What are they? Yes, it happens to be anti-RO antibody as well as anti-LA antibody. Anti-RO antibody is also called SSA antibodies, and anti-LA antibody is also called SSB antibodies. They are the ones which are implicated in the causation of this condition of neonatal lupus. Okay, right. So that is about the vignette 43. Next, moving on to clinical vignette number 44. A 6-year-old male child presents to the hospital with recurrent gross hematuria for 2 years. Usually these episodes occur 1 to 2 days after an upper respiratory infection. There is no history of burning micturition or pyuria. Urine examination demonstrated no pus cells and urine culture was sterile. Serum C3 levels were normal. See, in this question, it is something a child presenting with recurrent gross hematuria. That is a initial presentation in this particular child. You see that these episodes occur after an URI. That is what is the next clue. Then 2 more lines are there, that there is no burning micturition, pyuria, urine culture sterile. All tells you that there is no possibility of urinary tract infection in this child. Okay, right? So, with this history of recurrent gross hematuria or hematuria occurring after an URI, what will be your possibility? Usually we think about the commonest condition, which is PSGN, right? Post-streptococcal glomerulonephritis. Can it be PSGN in this particular case also? It is not PSGN. Why it is not PSGN? Because of few reasons. PSGN occurs 1 to 2 weeks after an upper respiratory infection like a sore throat. But here it is clearly written, it is 1 to 2 days after an URI. So it is not favoring PSGN. Number 2, PSGN usually has a single episode of hematuria, whereas here it is clearly mentioned child is having recurrent episodes of hematuria. That is also not favoring PSGN. Third important point, serum C3 in PSGN will always be low due to immune complex formation, whereas it is clearly mentioned here serum C3 levels are normal. So in this particular condition, my diagnosis is not PSGN. I have already told you all the reasons for that. So what is going to be the diagnosis in this particular case? It is going to be, yes, any other condition comes to your mind which is presenting with recurrent hematuria, normal C3 level, 1 to 2 days after an URI it presents. It is IgA nephropathy. It is IgA nephropathy. What is the other name for this condition? It is called Buerger's disease. It's called Buerger's disease. A very important condition, and it should be clearly differentiated from the other one, which is PSGN. Okay, so now if I ask you, considering this as IgA nephropathy or Buerger's disease, what is the primary treatment of this condition? Remember, these patients, they can have a long-standing kidney disease, and it is noted that after 15 to 20 years after the starting of the disease, 20 to 30% of the patient, that is when they go on to develop, when they go on to be adults, they develop a chronic kidney disease or a progressive kidney disease. So that is why we need to keep these children under follow-up and keep monitoring their renal functions. And it is found out that ACE inhibitors, they are very beneficial in decreasing the progression to chronic or progressive renal disease. So that is why ACE inhibitors are useful in the management of this condition. Next important thing is fish oils, which contain lot of this PFAS, that is a polyunsaturated fatty acids, like the omega-3 polyunsaturated fatty acids. They are found to have an anti-inflammatory role, and they are also found to decrease the progression of renal disease in these patients. So these are two particular medications which can decrease the progression of renal disease and are helpful in the management of this particular condition. Okay, so that's about the clinical vignette number 44. We move on to the last clinical vignette, which will be about this particular child who is a 6-year-old child presenting with abdominal pain and red raised skin rashes, mainly involving the lower limbs as shown in the given image. Can you see in this particular image those rashes which are like round lesion, something like a purpura, but it is clearly noticeable that they are not a usual looking purpura, instead a big purpura. You can even touch and feel them. So what do you call that? You call them as palpable purpura. Palpable purpura. So you have a child who is having palpable purpura involving the lower limbs. Along with that, child is also having an abdominal pain. What could be the likely diagnosis in this particular child? It's a very classical presentation of a vasculitis condition in children. Yes, what could be the answer for that? Yes, it is based on the finding itself, purpura. What is the name? Yes, it's called Henoch-Schönlein purpura, or what we call HSP, Henoch-Schönlein purpura. Okay, HSP, very typically characterized by this finding. Okay, how I made the diagnosis here? One, based on the palpable purpura, and that too present only in the lower limbs, number one. Number two, an associated finding in the form of abdominal pain. Some of these patients with Henoch-Schönlein purpura, instead of abdominal pain, they can even have a joint pain also. They can even have joint pain also. That could be the second set of finding in these patients. Okay, so first commonest finding would be purpura, which is palpable purpura. Second finding would be pain. It could be in the joint pain or in the abdominal pain. Third, few set of patient, like around 20 to 30% of the patient, they have renal involvement. Okay, they can have hematuria or proteinuria at the time of presentation as well. This is very characteristic of Henoch-Schönlein purpura. And please remember, in this particular condition, the platelet count, what happens to the platelet count? Is it normal or abnormal? It is absolutely normal. It is absolutely normal. This has to be very correctly remembered, because the usual reason for purpura and petechiae we study is thrombocytopenia or low platelet. But here it is only vasculitis which is causing the purpura, and that is why I am saying platelet count is normal in this particular situation. Now one more question also I have. After admission, this child developed hematuria and proteinuria. I told you renal involvement is possible, which is what is seen in this particular child. Renal biopsy was performed to evaluate this. What is a likely finding in the renal biopsy? Okay, I will give you a clue. You can tell the answer. It is something related to one immunoglobulin deposition in this condition. What is that? It is IgA deposition. Okay, IgA. Okay, in fact, this vasculitis itself is called IgA vasculitis. In fact, if you see the renal biopsy, you will see mesangial deposits of IgA, which will give you again a clue to this particular condition. And if you do the skin biopsy, you will see the characteristic leukocytoclastic vasculitis. Leukocytoclastic vasculitis. Now this leukocytoclastic refers to the damage caused by the nuclear debris from the infiltrating neutrophils which are seen in this particular condition. That's why it's called leukocytoclastic vasculitis, a classical feature of Henoch-Schönlein purpura, which you should make a note of, which is noted in skin biopsy. Okay, right. So that's about this particular clinical vignette of Henoch-Schönlein purpura. With that, I am concluding the discussion of clinical vignettes in pediatrics. I hope you get an idea about solving these type of questions, which will be mainly correlating with the clinical features And thinking about a diagnosis in mind, we have to evaluate further. So your questions can be like this. They can give you a clinical scenario and ask you what is the diagnosis straightforward, or they can ask you what is the next investigation you are going to consider in this particular child. Third, they can ask you what should be the best investigation to prove the diagnosis or definitive investigation for diagnosis in the child. And fourth, they can give you the scenario and directly they can ask you which treatment or drug will be helpful in this particular condition. These will be the pattern of clinical vignette based questions in the subject of pediatrics. I hope it is helpful and all the best for your exams. Thank you.